Hey everybody, this is Dr. Zach Kuwait here, Performance Sport and Spine, and today's video we'll be discussing hip impingement. So to quickly refresh our anatomy, the hip joint is a ball and socket joint made of the acetabulum of the pelvis and the femoral head and neck of the femur, which is the thigh bone. So related to hip impingement, there's two parts. There's bony growth to the femoral neck, which is called the cam, and then there's bony growth due to mechanical load on the acetabulum, which is called the PINCER. So what's causing these bony changes to happen in the first place? Well, it occurs during adolescence during periods of rapid growth and loading. So the type of load and the dosage of load is also relevant, as higher intensities or larger volumes may increase the chance of these bony changes to happen. And then lastly, genetics plays a role as well, as siblings are 3 times more likely to have these occurrences. So what does hip impingement feel like? Typically it's growing pain. Half the people have symptoms on both sides, left and right. Of the people that have the bilateral symptoms, it should feel the same on both sides. And then sometimes people will have posterior pain due to labrum irritation. So how do we diagnose hip impingement? Well, it turns out we need 3 things. The first is positive findings on imaging. So the second component would be appropriate symptoms. These would be such things as physical impairments, which would be like walking with a limp or growing pain increases the chances to hit by 7 times, or positive orthopedic tests can increase it by 14 times with lots of internal rotation. And then lastly, signs of femoroacetabular impingement, which would be reduced range of motion, reduced hip strength, poor trunk control, increased impingement with single leg squat, reduced dynamic balance, and then gait alterations. With all medical diagnoses, we should rule out all red flags, and this would include fractures, tumors, or infections, and also the lumbar spine should be ruled out, and this can be done by moving the lumbar spine, and it should not reproduce the pain. So now we'll go over the exercises for this condition. So the goals of the exercise are to improve range of motion, increase the strength of the hip, work on trunk control, and improve ballistic or plyometric retraining. For the exercise dosage, we recommend 3 to 5 times a week, 2 sets of 10 to 12 reps, resting about 30 seconds between sets. In addition, these will base off a tier system, so we'll start with tier 1, which is the easiest, progressing to tier 4, which is the most challenging. So for optimal loading strategies, the pain should be 2 out of 10 or less, and the intensity should be moderate, 4 to 5 out of 10, and then you should adjust which tier you want according to these metrics. So the first group of exercises will be addressing the adductor. So you'll need a band and anchor to something that won't move, and then place it around one of your thighs with tension point outwards. And we're going to do a glute bridge, making sure you feel like the band is pulling your leg outwards. And this would be the tier 1 or the easiest option, and we'll progress to more challenging options. Tier 2 for this group would be lay on your side with the affected leg down, cross the other leg over, and then keeping the leg straight, you're going to lift it up towards the ceiling, and then down, and then repeat. Again, you should feel some gentle tension on the inside of your leg or the adductor group. So a tier 3 version would be the same as that double leg, but a single leg version. And again, make sure to drive up with your hip and feel it in your buttocks, not your back. And the tension should be on the band, pulling your leg out, and your adductor should feel like it's resisting it. Tier 4 would be a standing version. So standing with the band around one leg, have your other hand hold on for stability, and with the band of the leg, pull it across your midline, feeling some gentle tension over the inside leg of those adductors, and come back. Again, as you progress, you can increase the band resistance or try to press it farther or hold it. But again, you should feel a tension on the inside leg of the moving leg. So now we'll work on the abductors or the lateral hip muscles. So the first one will be laying on your back with your knees bent. Place a PT band around your leg just above your knees, and you'll press your knees outwards, creating tension on the band, and you should feel some gentle tension on your posterior buttocks. Tier 2 is going to be a banded glute bridge. So with the band in the same position, you're going to drive your hips up towards the ceiling and back down, making sure you feel tension over your posterior glutes and not your back. And again, it's important to keep tension with your knees out towards the band as you maintain this movement. So tier 3 would be a seated position. So in a seated position with the band around your legs just above your knees, press your knees outward, creating tension on the band, feeling some tension over your posterior glutes, and your feet should be about shoulder width apart, and the band should not slip on your legs. And again, you should feel some gentle tension over your posterior gluteus. Tier 4 would be a single-legged version. So with the band in the same place, lift one leg up and drive up with the leg of the down hip, feeling some gentle tension over your posterior buttocks, trying to minimize the back recruitment. And try to make sure that you get your pelvis all the way up in line with your femur. And again, keeping some gentle tension on the band in an outwards motion. Tier 5, again, get that PT band anchored to something, place on the outside leg, stay over with the inside leg, and then press the leg out laterally. Now you may want to hold on to something with one of the arms to maintain balance. If you don't need it, that's fine. And as you press your leg out, you should feel some gentle tension over your posterior buttocks. So tier 1 for hip extension would be laying face down and then lifting your leg up with your glute. Now some people may find it a little more helpful to bend the knee so you can feel the glute work. You don't want to arch your back. So if you're feeling tension in your back, you need to kind of move your leg around so that you feel the tension in your posterior glute or buttocks. Tier 2 would just be a double-legged glute bridge. Really trying to emphasize the posterior glutes or the glute max more than the outside or the glute med. So again, you should feel the tension over the inside of your buttocks and less on the outside. Tier 3 would be a single leg version, and again, we're trying to emphasize the glute max, so more inside and less outside of the glute med. So you want to feel that gentle toe tension, more midline or on the inside and less on the outside. You may need to move your foot around to kind of emphasize that spot more. So holding the weight in one hand, press that same leg backwards, trying to pivot at your hip, not your back. And as you press the leg back, your torso should fall forward, keeping weight on your midfoot, and you want to feel tension over your posterior glute and your deep buttocks. Again, try to push your leg back rather than lean forward, and only bring your torso down as far as your leg goes backwards. So standing hip extension, this would be tier 4. So you're going to stand, place the band around one leg, and then pressing out with the band, you're going to feel your glute and your hamstring, press the leg back, and try to minimize any trunk or forward bending, and making sure you feel tension over your posterior glute. So for the hip flexor, you're going to lay on your back and bring your knee up to 90. Place your hand on your knee and then press your knee up into your hand, holding your knee in an isometric position. Now this may cause impingement for people, so if it's painful, then you're not going to do this one. Another version to strengthen the hip flexors is in a seated position with your legs somewhat straight. Just lift your legs up to tolerance. Now typically if your knee is more bent, it's going to cause more hip flexion, so keeping your legs straighter kind of increases that angle, and it may be better or more tolerated, but you might have to tinker with the angle of your knee and your hip to see if there's a position that feels better than others. So now we'll work on trunk control. So the first tier is a side plank on your knees with your elbow below your shoulder, making sure your hips go all the way forward. Now once you can do this for 30 seconds, you would progress to tier 2, which is going to be on your feet coming up. Now it seems like being able to hold this for up to 38 seconds is a good measure to go to, so you want to progress until you can get to hold it 38 seconds on both sides. So trunk control in this plane would be starting with a knee plank. That would be tier 1. Going to tier 2 would be a foot plank. And then once that becomes easy enough, you're going to bend one knee and then work on hip extension in the knee plank, repeating on both sides, and this would be tier 3. Again, when you do this, try to minimize any pelvis movement and focus just on using your hip to extend your leg. So now we'll go over functional or plyometric retraining. So the first tier would be just a gentle squat. Now again, you can adjust the range of motion to less initially and then work on increasing it as you get stronger and feel more comfortable with the movement. Tier 2 would be a step up. Maintain an upright torso and minimize any forward leaning. And again, you may need to adjust the height of the step to your current tolerance and then progress as needed. Tier 3 would be a single leg squat, starting slow and cautious, and when you're doing it, making sure to keep good pelvic control and try to minimize any tilting this way or this way as you do it. And as you get stronger, you can work on increasing the depth. Tier 4 will work on ballistic loading, so kind of taking some baby jumps and then increasing the depth that you land, as well as the power that you push up as you feel more confident or tolerant in the motion. Tier 5 would be ballistic loading, landing on one foot. And again, working on maintaining that pelvic control as you land, not letting it tilt or roll forward. And then as you get stronger and more confident, you will work on increasing your distance. And the last one would be just a hexagonal loading. So you're going to jump forward, to the side, to the back, and then return to the starting position, and then switch legs, trying to maintain pelvis control as best as possible. So what sports are these FAI impingements more commonly seen in? Rowing, golf, ice hockey, track and field, soccer, and basketball. And 2.5 times more likely to see this in high-level athletes versus sedentary people. So there are other conditions that may present somewhat similarly that need to be ruled out. So the first is the hip flexor issue. So the pain would be more of the hip flexor. Palpating the hip flexor would cause pain, and resisting the hip flexor in a muscle test would also reproduce the pain if this was the case. So the second would be adductor pain. So the pain location would be over the adductors. Palpation of the adductors would cause pain, and the adductor squeeze test would be positive for reproduction of the pain. The third would be abdominal pain. Now the pain would be located over the abdomen, and palpation of the abdomen should reproduce that pain if this was the case. Fourth would be the inguinal pain. Now this would be located over the inguinal ligament, and palpation over this area would also reproduce the pain if this was the case. And then lastly, pubic pain. Now this pain location will be over the pubic symphysis of the pelvis, and palpation of this area would also reproduce the pain if this was the case. So we briefly need to talk about the timeline and progression of symptoms. Now this is a schematic overview and doesn't necessarily hold true to every person. So initially, around 13 to 14 years old, people start to get these bony changes or cam developments, as you can see on the chart here. And then as it progresses in your early 30s or late 20s, you may start to get painful symptoms or positive impingement signs. And then progressing further into your 40s, you can start to get clinical arthritis of the hip. So for imaging, the first line choice is x-rays, and the two views would be AP pelvis and then done 45-degree angle to measure the degree of hip impingement. So for more advanced imaging, the MRI or MRI with injection is the preferred choice. Now CT scans are a little bit better, but due to the large radiation dose, the MRI is the preferred choice. And then again, lastly, imaging is only part of the diagnosis. So just because you have these findings on image doesn't mean you necessarily have it if you don't have the clinical signs and symptoms to go along with it. So now we'll discuss surgical management. So surgery should be a shared decision process between the patient and the doctor, and it should not be recommended as a first-line intervention. So the surgery may increase the risk of long-term degeneration of the cartilage, and about 50% of people see improvement at 2-year follow-ups. And then lastly, for athletes, only 70% of them reported that they returned to optimal performance after the surgery. So most people with these bony changes will not go on to experience symptoms, but about 50% of people, despite what they do at 2 years, whether surgery or rehab, will still experience some impact due to these changes. Thank you so much for watching our video on hip impingement. We really hope you found it beneficial. If you did, would you please like the video and subscribe to our channel, as it helps us reach a large audience.